And I will ask Dr. Padmasri Dr. Natarajan to start his topic, that is a traumatic vitreous hemorrhage, intraocular foreign body, retinal detachment, management of that. Please come. Dr. Natarajan.
Thank you, Dr. Lane, and thank you, Sanjeev, and thanks to the AOS for having this National Symposium on ocular trauma. So my talk is on management principles of ocular trauma, intraocular foreign body, traumatic retinal detachment, and suprachoroidal hemorrhage. So this is the main, when I have an injury, you need strategic thinking in ocular trauma. Strategic thinking is equal to individualized approach. Think again and again what is the most suitable line of management for the given patient. Retained intraocular foreign body occurs in about 5 to 40% of all penetrating eye injuries, and these injuries tend to occur more commonly in young males and frequently carry a good prognosis with timely intervention. Overall, 20/40 or greater visual acuity can be expected in up to 71% cases. Indication of removal of intraocular foreign body: persistent inflammation, mechanical damage, retinal tears, retinal detachment, reactive foreign body like copper, iron, chronic cerebrotic damage to the eye, and traumatic endophthalmitis. So majority of intraocular foreign body should be removed on an emergency basis. Increased risk of endophthalmitis, and becomes increasingly difficult to extract if it is more than the patient comes late with the fibrovascular membrane, organized vitreous hemorrhage, retinal detachment, incarcerated retina, and intraocular foreign body. So I always, most of the time, do the two-step approach. The first step should be wherever in the remote part of India, should be with a good initial repair. That means we use a good microscope. Fortunately, everybody can afford a microscope made in India, and anywhere, any smallest place in India in the remote. But the only thing is they are generally worried to tackle a trauma patient because of the prognosis, and I think the ophthalmologist should definitely do the wound repair and have a good rapport with the patient and the relatives so that they don't get agitated when they don't get vision. And so Ferenc Kuhn and myself, we believe now we should do the second intervention within 100 hours or 6 days, where we then do the secondary surgery like vitrectomy, whatever, relaxing retinectomy, retrieval of foreign body, etc. So localization of the foreign body is very important. Clinical examination, gonioscopy, indirect ophthalmoscopy, focal corneal bedewing, and biomicroscopically visible corneal, lenticular, or vitreous tract, as you see here. So if the foreign body, you can classify well visualized and poorly visualized, so you can accordingly use the instruments with the magnetic or the non-magnetic. So this is just to show a pencil magnet, a rare earth magnet, and also the one made by the Grasshopper, which is like a pencil. When you press, the magnet will come for smaller intraocular foreign bodies. So the rare earth magnet is a small, delicate, precise internal use, and we also use the giant magnet. Maybe Mohan remembers his. When I worked with his father, we have removed the giant magnet. If you don't remove the metal thing, the entire speculum, everything will come with the magnet. And this is the pencil magnet, which you see here, and where I also use the electromagnet for the vitreous forceps, and it's a diamond-coated foreign body forceps. And this is which opens 13 millimeter. One Russian ophthalmologist called Stornikov, when he came to Mumbai in '95, I got this. So it opens almost 13 millimeters for a wide mouth, large foreign bodies. And this is for a glass foreign body. I designed an instrument where you can have a suction over the forceps, so that because the glass foreign body can slip and damage the retina. So whatever you do, even you use the PFCL, the glass will sink through that. I'm glad my colleagues Dr. Manish Bapai and Mahesh Shanmugam made a claw intraocular forceps, where it's a novel intraocular foreign body published in Indian Journal of Ophthalmology, which I used a lot in the pellet injury in Kashmir. So intraretinal foreign bodies is more difficult and more hazardous, and if intraocular foreign body can be localized by indirect, then it can be removed by translator approach. This is a pellet ocular trauma, where I've done a pars plana vitrectomy and removed the foreign body. So here you see the corneal wound repair done, and it's already a lensectomy done. I made a 12 o'clock incision. That's my contribution. We are in the process of publishing this, where the four-pronged forceps grasp the pellet within the vitreous hemorrhage so that it doesn't unroll and fall down. So I don't remove the total vitreous. So I remove this and then close the scleral wound with a wound, and that's the 4x4 polygonal shaped irregular pellet made of lead. and then close the sclera and conjunctival and go ahead with the 23 gauge trocar and cannula, and you can see altered vitreous hemorrhage completing the vitreous base excision. And this was an aphakic eye. You can see retina was attached, and there was subretinal hemorrhage, and there is an exit wound of the pellet. One more pellet had gone through and through, close to the optic disc. So the patients who had a macula and optic nerve all right, they were having good vision, but people who had a macula or a optic nerve injury had a poor vision, but still surgery was definitely required. And wherever there is a wound, where we made like a coloboma choroid and did a laser, and this patient almost got with the aphakic correction 6/9, so we can do a secondary implant, which Dr. Tariq is here from Kashmir, and his team have done that. And this is the patient who had a submacular hemorrhage with a pellet injury, and we did a cataract with the intraocular lens, and then the vitrectomy with oil, and the vision was counterfinger because of the irregular shaped cornea, and later that can be corrected. So you have to do multiple procedures to, like retinopexy, retinal reattachment procedures, cataract, intravitreal injections, depends. And then here you have the 25-year-old man with a firecracker injury with a visual acuity was PL inucrate. Only in injury with no perception of light we can do a surgery. So here it's the, you can see the 3-port pars plana vitrectomy in progress, and I'm now removing the vitreous inducing PVD, and you can see that the induction of PVD and then removing the posterior surface of the vitreous, and looking vigilantly looking for the intraocular foreign body within the vitreous hemorrhage. The idea is that if the foreign body is freed and it falls on the retina, it can also damage the retina, and when you are going to use the forceps, and you can actually touch the retina and have a problem. So I am now clearing the vitreous hemorrhage and looking for the foreign body. So that's why you have to do a B scan, you have to do a, depending on the, if it is a MRI or a CT, depending on the type of injury, you decide the investigation, and localization of foreign body is important. In spite of all the experience, sometimes intrascleral foreign body, or if the foreign body is projecting outside, in the, if you can finally saw the pellet is there in the vitreous hemorrhage, and that's what I have located. So now I am using the same 12 o'clock incision and then grasping with the forceps and removing it. So still the remnant of vitreous hemorrhage is there. The idea is, as I said, the foreign body not to fall on the surface of retina. 1 minute, sir?
Yes, sir.
Yeah,
Okay.
you can take
So
one.
this is the follow-up counting vision, and this is the glass foreign body which has been removed from the vitreous, kept it on the surface of the iris, and then you grasp it and remove this. And then this is again a THORN foreign body, and where there was an endophthalmitis, remove the corneal foreign body, and then do a lensectomy, vitrectomy. This was a child. And then this is again a metallic foreign body being removed. So I think, and then you have a suprachoroidal hemorrhage with a following rotoraphic accident. You can see the entire cornea being sutured, and then you see the back surface of the retina, which is because the temporal retina with the giant tear incarcerated in the nasal retina. So I'm opening up the fold, and then I use the PFCL to, and now I'm using the chandelier illumination and using 2 forceps to open the unfolding the retina, and then reattach the retina and do a PFCL oil exchange. You can see now the PFCL, under the PFCL the retina is totally attached, and then do a laser. Suprachoroidal hemorrhage was done. So whatever looks with an OPL and the gone case, I think we should attempt in a trauma, and so earliest the better, and we explain the prognosis and then do the surgery. So this is a pre-op and post-op with a corneal injury, and then the expulsive hemorrhage also we can operate. Thank you.
Thank you, Dr. Natarajan, for a lovely video. We know you got a huge experience, one of the only surgeons in the country doing vitrectomies, hundreds of them in Kashmir with the pellet injuries. Thank you so much for your presentation.